Okay, we're live.
Hello, everybody, and welcome to the September board meeting of the Connector. It's an important meeting today. We'll be discussing a lot of important topics, including voting on the seal of approval. To start our meeting, Kathy, I think we need a roll call.
Hi, Kathy, are you on mute? Kathy?
Well,
Let me just go see. I'll be right back.
we're going to make sure that Kathy's okay and ready to go before we can actually have our roll call and start.
I am here. I'm back. I got kicked off.
Okay. Kathy's back.
I'm back. Okay.
Wonderful, Kathy. We're going to do our roll call to start. And for those of you that haven't noticed, Secretary Sutters is not able to attend today. So I am doing my best to kick us off and share the meeting. Kathy.
Ready for roll call. Kevin. Kevin? I'll come
Here.
back. Okay.
Thank you.
Michael.
Here.
Okay, Ruth.
Present.
Mark.
Good morning.
Cassandra.
Here.
Dimitri.
Here.
Lauren.
Present.
Nancy.
Morning, Kathy.
Morning. Matt
I'm here.
and Rena.
Yes, I'm here.
Thank you.
Great. So welcome, everybody. Our first agenda item is to approve the minutes from the July meeting. Do I have a motion to approve?
So moved. Second.
Great. Kathy, can we do a vote?
Yes, we can. Kevin.
I'm abstaining because I wasn't out there the last time.
Okay. Michael.
Aye. Approved.
Okay, Ruth.
Yes.
Mark.
Yes.
Cassandra.
Yes.
Dimitri.
Yes.
Lauren.
Yes.
Nancy.
Yes.
Matt
Yes.
and Rena.
Yes.
Thank you.
Wonderful. And now on to our second agenda item, which is the executive director's report. So Lewis, you're up.
Good morning, and we do have a full agenda this morning, but before introducing the agenda topics, there are a few matters to note. I want to highlight a member renewal issue for 2022 that was created during our annual renewal process and will require some significant attention from the connector through the upcoming open enrollment. As we started the renewal process for 2022, we found that a higher number of members are expected to lose subsidies. Instead of our usual 20 to 25% of members losing subsidy, we are looking at about 60% at this time. This is a result of the IRS automatically amending 2020 tax returns more than usual due to the tax filing changes created by the American Rescue Plan that had provided tax relief to people who had been on unemployment income in 2020. When a return is amended, it results in income data that differs from what exchanges like the Health Connector are required to use to verify subsidy eligibility. And when this happens, those members lose their subsidy eligibility until and unless they take steps to verify their income. This process to update is fairly straightforward. Members go into their account and update their income, or don't change their income if the information is correct, but do go through the income section and press save. Members will then be updated back into subsidies at the right level, although they will likely have to respond to a request for information notice via the mail to confirm the change. Because of the high volume of impacted members, we estimate more than 130,000 members are impacted. We're going to take measures to communicate with these members and encourage them to take immediate action. We are working to see if there may be a federal policy solution to this development that could prevent these individuals from losing the subsidies. But so far, there is no guarantee of that, and we are proceeding with a communication plan to our members to make sure they know exactly what to do to qualify for subsidies as we head into plan year 2022. Our original member communications plan included 5 items directed to members losing subsidy, encouraging them to take action from October through December. We are adding additional communications in September and December. We are providing our navigators with lists of their clients to conduct direct outreach and help them update their information. We will be engaging with stakeholders, including advocates, carriers, and other assisters to highlight this issue and encourage across the board member support. We will be highlighting this issue and the remedy on all of our social media accounts, and will feature messaging in all public events as we talk about open enrollment across the state. We will continue to keep the board posted, and we'll include an update on this topic in our open enrollment preview at next month's board meeting. And it's particularly important that we keep members in subsidy, because the enhanced American Rescue Plan subsidies carry through next year, plan year 2022, and they're just a fantastic support for affordability. We'll have a presentation on affordability later in this meeting. Moving to the presentation.
Louis, could I ask a question?
Yes.
Before you move?
Yeah.
I mean, this is one of those ironic unintended consequences of a good policy change. So this must be an issue in every state.
It is.
I assume we're working in partnership with others, and it also seems to me that the burden, if there's no policy fix, can't just fall on individual states to try to communicate, but the feds have some responsibility for additional, outreach to people. So I assume we're trying to work on both those fronts too.
Certainly, I can confirm the first 2 parts, Nancy. We are working with other states, with Jason Levitas, who's formerly a Treasury person, to coordinate with CMS. And it is a problem that is not ours alone. It's shared by several other states. There are some states that might find it not a problem because they may not be doing certain income verifications, but with several other states, including significant size ones. So we are working with other states. We are working in conjunction with outside expertise and CMS to search for a solution. We had not yet broached the topic of the federal role in communicating, but we will. I think that's an excellent idea.
Louis, is there a potential for soft landing with regard to 130,000 should the subsidy not be continued?
Dimitri, this afternoon and real time, really over the past week, we have really been exploring options because I would very much like a softer landing than counting on every individual of the 130,000 to understand what must be done. So we will bring this back to the board in October, but we are actively looking for a softer landing than simply dropping people.
Thank you.
Louis, when will we get a sense of how this is working? And how long, do we have? There's some grace. I'm a little confused about the grace periods and other sets of things that play out and how all those things interact.
Yeah, so a few things. Clearly, this is entirely about plan year 2022. Massachusetts was the first state to really uncover this because we're among the first to run our eligibility redeterminations in anticipation of the new plan year. So people are not affected with this problem for the balance of 2021. So we're talking about a 2022 issue. We found it in the course of preliminary eligibility for 2022, which is now complete and notices have been mailed. And so the changes that are necessary really need to be made between now and the premium billing announcements later and final eligibility really up until December 23rd for January enrollment. But the sooner the better, because we need to be using these next few months productively to resolve this in some form. And I hope that responded to what you were asking, Michael.
Yeah, I think it did. I'm not 100% sure, and it sounds like you're not necessarily completely, maybe obviously much better than I, exactly the timing of how things will happen from the members' point of view, like where they are now, what then they're going to be told, what they're going to have to do, when they're going to have to do it by, those types of things.
Well, because preliminary eligibility, this process in Massachusetts, that's a joint process that we run with our Mass Health entity, is complete, and those notices have been mailed. People will be getting notices soon indicating that if they haven't already received them, indicating the loss of subsidy. But the notice itself will ask that the member goes to update their income information. And so many members may do that, but I suspect many others don't. On an ordinary basis, as we look over the years when we have 20 to 25% subsidy loss, you notice this curve that starts in August at 20 to 25% subsidy loss and gradually works its way down to a much lower level by the time open enrollment is done because people update their accounts. We just have a much longer tail to work on this year, or a much deeper tail to work on this year. So unless there are any other questions on this topic, I'll move to a quick synopsis of some of the agenda items. Okay. Thank you for your patience today. In open enrollment business today, we present to you the final seal of approval for plan year 2022. Among the things occurring for plan year 2022, we will be expanding coverage of insulin delivery methods at low copays, building on our existing equity-driven insulin initiative. Today, we are also providing you with data and background on two parts of our overall market in Massachusetts: premium trends over time and healthcare sharing ministries, and how they both intersect with the state's individual mandate. And finally, today, we will provide an update on our vital contact center reimplementation work and where that stands. Our current vendor over the last 2 weeks of August had a series of systems outages which impacted their IVR and telephony systems. The net result of this was member disruption that our current vendor is still working to fully resolve. But we anticipate using the long Columbus Day holiday to transfer our call center services to Accenture, and that Accenture will start taking calls from members on October 12th. Accenture has completed hiring and is conducting training through September. And as is our course in prior transfers of key vendor partners. Joining us today to introduce himself as a principal of the firm and speak on behalf of the new contact center team is Terry Westrup. Terry is the managing director of health and public service operations for Accenture. And because it's a small world over long periods of time, the thing I know about Terry is that in engagements, he keeps his word. So Terry, do you want to say a few words?
Thank you, Executive Director Gutierrez. And thank you, Dr. Chernew and CCA board members for the opportunity to talk at the Massachusetts Health Connector board meeting today. As Lewis mentioned, my name is Terry Westrup, and I'm a managing director within Accenture's business process outsourcing services business, and I'm a leader within our health and public service sector. I've also been engaged as in executive oversight of our work with the Mass Health Connector over the last 6 to 8 months. On behalf of Accenture, I want to thank you for entrusting us with these vital services supporting healthcare coverage for the citizens of the Commonwealth of Massachusetts. I want to stress that we understand the importance of these services, particularly during the public health emergency brought on by the COVID pandemic. In addition, we understand the critical time frame we are in during the open enrollment period and the importance of ensuring a smooth transition. We have had a team of senior, experienced delivery executives overseeing all aspects of this operation, and we commit to doing our best to make this a smooth transition for the Mass Health Connector. Finally, I want to stress that I'm here to represent Accenture's commitment to support the connector's high standards of service as we transition these critical services. Finally, thank you again for the opportunity, and thank you for your time today.
Thank you, Terry. Any questions for Terry?
I had a quick question. Good morning, Mr. Westbrook, and welcome to the board meeting. My question to you is, I'm a strong proponent of local hire as a government agency. I was curious as to the location of the call center and whether or not the call centers were being staffed by resources from Massachusetts and that we were reusing our taxpayers' dollars in Massachusetts.
That's a great question. So we are operating, as most service providers are, in a remote work, virtual work environment. And we've set up all of the technologies and management procedures to manage that effectively. I don't have the numbers on the split of resources, but we have rehired some of the people that are experienced and that are Massachusetts based. But I can follow up with the split of where all the people are located. But it is a virtual environment, and we have had to draw on resources from across the country.
Thank you.
Lewis, question, if that's okay.
Sure.
So welcome, and we're very glad to be partnering with you. So what have you observed and learned about what went so wrong over the last year or so that's going to inform how you proceed?
So there are two things that we've observed during the COVID pandemic related to operations in general, contact center operations more specifically. So there's a couple of things. The more general thing is that as service providers had to transition from working in a facility to working virtually, there are a number of changes you have to make in terms of the way you manage an operation, a contact center operation. And there are some technologies that really help enable that. And if you don't have those technologies and those management procedures in place, it makes it very difficult. And this is a general trend. So what we did early on, we were engaged in a lot of contact center operations for agencies that were facing massive increases in volumes. So we had already worked with some technologies that enable that virtual work environment and that enable the supervisors and managers within the operation to get visibility to what actually is going on at the individual level. And that's very important because, in a facility, obviously, you have line of sight to the workers and you have a certain amount of management by walking around, which is important. And that kind of environment, you just don't have that in this virtual environment. So some of the tools and management procedures are very different. The other challenge is, during open enrollment, during this time, you're seeing much greater volumes. So it's important to recognize that. And then finally, there is a higher level of fallout in these virtual environments. You have to plan for that. So those are some of the things we've found generally across the operations we are running and adapted our services accordingly.
And if you were one of us on the board, what are the 2 or 3 things you think we should be paying very close attention to be sure that, as Lewis said, you deliver on the promises you've made to us and, more importantly, the people we serve?
So we are one of our philosophies within our operations management is a focus on metrics. So and we stay on top of it literally hourly throughout the day. So understanding where we're at on the metrics, certainly leading up to it, understanding where we're at on the staffing, and then finally where we're at on the technology. Those are probably the 3 most important in my mind.
So we'll pay attention to those.
As will we.
Thank you all. So I'll conclude the executive director report, and thank you, Terry, and our board members. Thank you as always for your guidance and support as we move to open enrollment for 2022. As always, this time of year is very busy, particularly with the transition activities over the next month. But we're looking forward to supporting our members in re-enrollment and welcoming new members into continued robust American Rescue Plan subsidies for 2022. So thank you.
Thank you.
Thank you very much. And I think Godspeed. And Lewis, thank you. Our next topic is an important one, our final seal of approval discussion for 2022, which we will then have a vote. We have, I think Audrey's probably going to start, then Maria Joy, Sam, and Edith. So Audrey, am I turning it over to you to start?
You are. Thank you so much, Vice Chair. And good morning, members of the board. Today, the staff of the Health Connector returned to you with a proposal for final seal of approval for health and dental plans for plan year 2022. As you all know, the seal of approval process is a year-long, multi-step undertaking revolving around certification of products to be sold to Health Connector enrollees. Just to situate where we are in this timeline, our seal of approval, RFR, was issued to the market back in March. Responses came back in from interested market participants in May, kicking off an in-depth review and analysis of responses. We came to you back in July with a conditional seal of approval recommendation. Since that time, we received final approved rates from the Division of Insurance and are now before you with a recommendation for final seal of approval for plan year 2022 in advance of our open enrollment, which kicks off on November 1st. Next slide, please. The final shelf of the Health Connector product offerings for 2022 is largely one marked by stability. We have maintained a connector care program design that continues to offer affordable choices for our enrollees up to 300% of the federal poverty level. For non-group enrollees above that level, and for our small group enrollees, we continue to offer a broad range of carriers and products representing an array of plans from 9 medical carriers and 2 dental carriers. Based on final rates, Connector Care base silver plans are increasing an average of 6.6%, and unsubsidized and premium tax credit only base plans increasing an average of 6.9%. I will hand it over now to Sam to take us in greater detail through the qualified health plan offerings.
Thank you, Audrey, and good morning, all. To briefly recap from our conditional seal of approval meeting in July, the Health Connector received responses from 9 medical carriers, submitting 52 non-group and 64 small group qualified health plans. The majority of plans are offered are designed with standardized cost sharing on platinum, high gold, silver, and bronze metallic tiers. QHPs in 2022 will include expanded coverage of insulin delivery methods at low copays to improve upon the existing equity-focused insulin initiative. In whole, the product shelf is mostly stable compared to plan year 2021, with the new and closing plan changes attributed to Fallon Health's change in product strategy. Fallon will continue to offer all required products and continue to participate in the Connector Care program on the same network and service area as 2021. Approximately 1,600 APTC only and unsubsidized eligible members will be impacted by Fallon's product change. The majority of these members will be auto-renewed into the same metallic tier in Fallon's remaining community care network. Other members will be renewed by the HICS system into the lowest cost plan available to them from a different carrier in consideration of the carrier's service area and members' residence. Both Fallon and the Health Connector are sending letter and email communications to members to check existing provider coverage in order to ensure the plan and provider offering meets each member's needs. Members shopping through the HICS will also see a network note associated with Fallon's plans to indicate the network is smaller than Fallon's 2 closing commercial market networks. And as mentioned, Fallon's product offering changes will not impact the Connector Care program participation, and members in 2021 will receive the same coverage as 2022. On average, non-group members will experience a cumulative 6.9% rate increase before aging and 8.5% increase after aging for unsubsidized and APTC-only QHP premiums, though increases vary by metallic tier as displayed below.
Sam?
Yes.
Yeah. Thank you for displaying this. These numbers, I think the word described in the previous slide was moderate. I think that's fine as a word. This is more than, for example, the Massachusetts spending cost target. Obviously, the actuarial values are saying the same within each of the metal tiers. So is this indicative of broad healthcare spending growth in the Commonwealth? Is there something else going on for these premium increases that I'm not seeing? Is this what we expected? Any more color commentary?
I think we might ask Kevin for input on this score, as the connector is probably not the best to speak to the rate foundations. Is that okay, Kevin?
No, thank you, Louis. I appreciate that. And for all who may not be familiar with me, I'm the Deputy Commissioner of Insurance and have looked at the rates for many years. It's been a challenging year, and for 2022, the carriers are feeling greater pressure associated with COVID-19 tests, COVID-19 vaccines, and with increased cost pressure from providers associated with PPE costs. It is something we have monitored a great deal, utilization in 2020 and 2021. Recognize that we all know that in 2020 there were dips in utilization, but it all came back in 2021, and there's projections that it will be stable for 2022. The real increased costs that I'd really project that most of these are attributable to are associated to COVID-19 expenses going forward. We pushed hard on all of these projections, especially as companies try to project what the costs would be for boosters and additional vaccines going forward, for additional treatment costs. But one big problem that we do see are the unit cost pressures that we are aware the carriers are pointing out, especially for hospitals and also for providers who are looking for ways to factor in the increased cost of PPE into their actual reimbursement rates. So it was not a year that we were happy with the level of rate increases. We did push back on many of the company numbers, but it is something that in a 45-day period, we have a difficulty to actually push to actually disapprove any rates. And we found this was the point that we could actually push the process to complete the actual filings by the August 23rd date the connector did need. But I would say this is really based upon future price needs and a lot of the contract negotiations we are hearing between the carriers and the providers.
Thank you. That was useful. I have to say I don't think it's particularly sustainable, but we're in a particularly unique period. So I'm certainly in no position to say otherwise. So I just appreciate the explanation.
Sure.
Sorry for interrupting, Sam.
Kevin, can I ask something? Because I find these increases actually surprising and concerning. And I have been in your seat, and I understand the difficulties of the rate review process. But I think particularly in light of the financial performance of the plans, not only last year, but actually for many of them continuing into the first half of the year, many of them continue to have profit margins that are bigger than I have seen in many years of looking at them. Many of them have actually quite low loss ratios in individual coverage, where the financial results, at least so far, seem particularly poor is in the Medicaid line of business. So I look at these and I think there's certainly just an enormous testament to the failure of the cost control laws that we've put in place over the last 10 years. As Michael noted, these are twice, if not more, the benchmark increase. So, I wonder how much subsidy there is built in for other lines of business that's now being borne on the backs of our members. So some
I'm sorry, go ahead.
Just don't comport with what the financial results look like, at least the ones that I've seen.
No, and I appreciate it, Nancy. It's something that we don't only look at merged market rates. We also compare them to large group rates in the market. We're seeing the same trends apply to the large and to the small group markets. What we need when we look at all of the years of rates and also financial results to separate what happened in 2020 compared to 2022. All are aware that for 2020, carriers that had good financial results owe rebates to the market. And we are aware rebates have been sent out to many individuals in Massachusetts associated with the relatively strong performance the carriers had in 2020 because of lower utilization. For 2021, likewise, any amount that actually is below the medical loss ratio of 88% will be in rebates for the following year. In looking at 2022, we weren't looking specifically at the performance in 2020 or 2021 as much as how those trends affected 2022 costs. I understand your points regarding the relative strength of some of the insurance companies, and that was definitely used by the Division of Insurance as we pushed back on many of the rate filings. I think that the key that the board will need to continue to recognize, there are rebates that will come whenever companies have better performance than they project. But what we looked at for 2022 were based upon what we thought were the best cost estimates that we could push back on based on our actuarial assumptions and actuarial questions for what the cost would be for 2022. But I would state that this is what we are seeing not only in the merged market, but also in the large group market. So thank you.
Yeah, and I mean, I think rate review is an important tool, but it's only one tool and it can't deal with increasing provider dominance and increasing market power and other things, which I think as a state we've been unable or unwilling to address, but it's very clear we're going to have to do something, because these are just, as Michael and other, these are just not sustainable increases.
I'm not really sure what you said there in the brief, mute Nancy, but maybe that's good. Maybe we'll do Rena and then Mark.
Super. So good morning. I agree with the comment about these increases being, I think, higher than moderate and quite disappointing. I would prefer to take a different angle towards my concern, though. I think that no stakeholder in this business that we're looking at should be held exempt from the issues. And while the rate review process and the focus on the insurers is definitely an important factor, I heard Kevin say that increased payment rates, increased unit cost to providers was part of the driver of the projected future increases. And to me, that continues to raise the question of, what is going on with this statewide benchmark. We had a merge market advisory council that was focused on understanding drivers of cost in the merge market and recommending solutions. And we do not have this under control. And I just feel very strongly that just focusing on insurer profitability and the promise of rebates is completely missing the opportunity to get at the root cause of these higher costs.
Mark?
Thank you, Michael. Appreciate that. And good morning, everybody. I think I'm on record many years in a row saying health insurance is expensive because healthcare is expensive. When we look at underlying medical trend, 50% of trend is unit cost, which Kevin already pointed out. Actuarially, these numbers are what they are because of the underlying contracts that exist between the provider community and the insurer community. The reality of COVID was there was a tremendous amount of lost revenue in the hospital systems, and they are trying to recover some of that. If you look at the underlying medical trend, typically around 7 or 8%, it's now feeling pressure because of COVID loads that, depending on the carriers, can be anywhere between 3.5, sometimes as much as 5% additional loading into the trend factor. So Nancy, just so you're aware, it's pressure at every end of the marketplace. At the self-insured end, it's less so because trend doesn't have margin baked into it like the carriers put into their premium rates. So there is a little bit of relief there. There's no premium tax for self-insured employers. Well, there is premium tax on their reinsurance, but not on the entire portion of the premium that they pay. So there's a little bit of savings for larger self-insured employers there. But the underlying medical trend and pharmacy trend are absolutely unsustainable. The other thing that's going to hit the merge market, which we have not felt yet, is we just lost through the ACA, and I'm sure Lewis could update us on this. We're losing the rating rule changes that are going to put more pressure on the merged market in the small group marketplace. So we now don't have any more flexibility granted to us by CMS. That's also going to put additional pressure. So the reality is, unless we continue to make the rules different, in other words, the disclosure of the cost, which we already have a national transparency law, which the hospital systems are fighting. How do we attack the underlying challenge, which is unit cost? Units of service are absolutely a part of it. It's 35% of trend, but the evil doer is unit cost. And until we get that under control, we're going to continue to see these types of pressures, cost pressures.
And I'll simply confirm what Mark said. CMS has denied further use of non-ACA rating factors for next year going forward.
Okay, so I'll look at this discussion and when we get to review the minutes for next meeting. I think, Sam, we should probably continue. The summary of this is, I think there's frustration broadly at aspects of what's going on, much of which I think is beyond what we can deal with in this particular session. Although I do think this is something we're going to have to work with and continue to focus on an ongoing basis, because admittedly it's a somewhat unique year, but we're not going to be able to handle this level of rate increases for an extended period. And I think to the extent that we can do better, we can explore ways, but I don't think that's where we are for the business at hand. So Sam, do you want to pick up?
Yes, and thank you. Just to add a additional perspective, we also modeled an example of premium changes year over year by carrier, including membership share, and we have a modeled rate on the far right. Unless there's any other questions, I think we could move along to the connector care portion.
Great, thank you, Sam, and good morning, members of the board. So on the connector care side, as we indicated at the July meeting, staff are pleased to see a stable connector care landscape for 2022 with no changes in participation or service area coverage. We do continue to see a few regions of the state with only one participating carrier, and our interest remains in bringing additional carriers with sufficient provider choice to those areas in 2023 or future years to ensure members have equitable access to a range of providers regardless of their income level. So moving on to connector care enrollee premiums. Connector care enrollee premiums are silver plan premiums reduced by federal and state subsidies according to members' income. The proposed connector care enrollee premium schedule, which can be found in the appendix, in addition to guaranteeing at least one plan choice at the affordability schedule, offers modest additional support for members selecting higher cost plans with assistance concentrated for members at the lowest end of the income scale. So unless any questions on the connector care program, I will go quickly through dental. So on the dental side, there's no change to 2022 dental product offerings. We have the same carriers intending to submit the same set of plans, to offer the same set of plans in 2022. And on average, dental members will experience a rate decrease of 1%, though with underlying variation by carrier and market segment.
Maria, can I just ask, I am particularly stunned the Delta Dental has an increase in a last 18 months when utilization and costs went down and profits went up. That was particularly pronounced in dental. So do you have any information about why the Delta rates didn't go down? What Altus is showing is kind of more what I would have thought.
Sure. On this, I may defer to Kevin if you have any color commentary to add on the dental side.
Well, I would say that Delta Dental is seeing utilization coming back compared to what did exist in 2020. And their projections for 2022 are actually expecting that utilization will be at a relatively normal rate of increase. They have pointed out PPE is related to certain of their charges, but this is more associated with utilization changes as opposed to unit cost. They are not seeing that unit cost is the driver as much as really individuals getting more dental care as they are returning to what they actually had received before. My recollection too is that Delta Dental had a pretty substantial rate decrease between 20 and 21. And I think that they actually are adjusting for parts of the decrease that they had between 20 and 21. So am I correct, Maria, that they did have a decrease between those 2 years?
I believe so, Kevin. I'll have to go back and look exactly the number, but that does sound correct, yes.
That makes more sense. So thank you, Kevin. That would explain why they're not having a decrease. Maybe.
And my recollection was it was about an 8 or 9% decrease between 20 and 21.
Given their loss ratio, that would be very appropriate.
Thank you. So lastly, just a few next steps in 2023 insights to share. So today's final seal of approval vote will allow staff to proceed with the use of plans for final testing activities, APTC calculation, and renewal notice creation before plan shopping opens on November 1st. In addition to these open enrollment activities, we're formulating our 2023 seal of approval policy priorities, which include improvements to the Connector Care program to promote more equitable provider system access, support of EHS's behavioral health roadmap, plan features aimed at closing health outcome gaps based on racial disparities, and furthering opioid use disorder treatment. Staff will seek board member input as policy development continues throughout the fall and winter in advance of the 2023 request for responses release next March. So that will bring us to the vote.
Wonderful. So I need a motion. The vote is, to recommend the final seal of approval for qualified health plans and qualified dental plans by the carriers listed.
So moved.
Second.
Thank you, Dimitri. Kathy, can we do the roll call?
We sure can. Kevin?
Yes.
Michael?
Yes.
Ruth?
Yes, but I would also like to be on the record as sharing the concerns expressed by my fellow board members about the impacts that we're seeing.
Mark?
Yes.
Cassandra?
Yes.
Dimitri?
Grudgingly, yes.
Lauren?
Yes.
Nancy?
I'm trying to decide. I'll vote yes, because I think voting anything else is not constructive, but.
Okay, Rena?
Yes.
Thank you.
Okay, the
Sorry, this is Matt. I didn't get my name called, but I'm a yes as well.
I'm sorry, Matt, I missed.
That's
talk
okay.
over you.
And Matt was the second on that, Kathy, as well. I think.
That is true.
I'm sorry for not picking up on that, Matt, but we have gotten to the same place, which the motion carries. And for people reading, they can capture the tone of this discussion. But nevertheless, the motion does carry, and so we will move forward. Our next agenda item is on trends on healthcare affordability and premiums in Massachusetts, which is quite appropriate given the discussion we just had. So Marissa, you are up.
Great. Good morning. Put my slides up here. Okay, great. Good morning. Today I'll provide an overview of the premium schedule created each year to support implementation of the state's requirement to carry health insurance, including trends over time and its interaction with the state's affordability standards. Individual market premiums have grown at a faster pace than the premiums deemed affordable under the affordability schedule, reducing the likelihood that non-group plans offer an affordable pathway to coverage. Despite that, coverage rates have remained high, likely due to premium subsidies under the ACA and high levels of employer-sponsored coverage in the state, though cost sharing as a barrier to care has also grown. The Health Connector supports administration of the state's individual mandate in a number of ways, including setting coverage and affordability standards, managing hardship exemptions, and publishing a premium schedule every year. The affordability schedule, which will figure in today's presentation, sets a percentage of income considered affordable for households of various sizes and income ranges, with higher income households considered able to spend a larger portion of income on coverage. Since 2015, the affordability standards themselves have stayed steady, while the incomes associated with each bracket increase gradually as the federal poverty guidelines increase, driven by changes in the Consumer Price Index, or CPI. At tax time, state residents file the Form Schedule HC with their state return, and that form walks them through reporting any coverage they had during the year or assessing whether affordable coverage was available through any of three sources: an employer, connector care, or private non-group coverage, which will be the focus of today's discussion. To support taxpayers in determining whether non-group coverage was affordable, the Health Connector creates a set of tables showing the lowest cost plan available through the Health Connector at a variety of ages, family sizes, and regions. In general, this means it reflects premiums for bronze level plans, though it does reflect catastrophic plans for individuals age 30 and younger, and we did have a silver plan in the mix one year. And while it may not capture each individual's particular circumstances, it's a very close reflection of what was available to them. So this slide shows the premium schedules from 2015 and 2021, along with the change in dollar amounts between the two, which translate to a 41% increase in the western part of the state, which is region 1 in the schedule, a 31% increase in central and eastern Massachusetts, region 2, and 74% on the islands, region 3. Of note, however, a real person would experience an even larger increase, as they would have jumped to a new age bracket over the time period between 2015 and 2021. And further actuarial value constraints on benefit richness mean that the bronze plan in 2015 schedule would be considered a silver plan this year. So in addition to higher premiums, these plans have higher cost sharing as well. And for comparison, the CPI that's used to update the poverty guidelines grew 12% over this time frame. Before I show you some scenarios and how they play out with respect to affordability over time, I'd like to provide a little more context that I think is important as we review. First, premium subsidies are not accounted for in the premium schedule or affordability determination. Until this year, there were limited subsidies available to households outside connector care, but the American Rescue Plan provides far more generous tax credits, and importantly, provides them to older adults and residents of high-cost areas especially. You can see in this table a comparison of the percentage of income our affordability schedule says could be spent on insurance alongside the percentage of income that the ARP targets for silver tier premiums, and they're really quite closely aligned. Prior to ARP, in some of the scenarios we'll get to, a couple or a family earning $80,000 to $100,000 per year would have been just outside the subsidy range, but faced with a premium as high as 17 or 18% of their income. If ARP subsidies become permanent, it may be worthwhile to think about if and how we could reflect that net premium in the context of the individual mandate. So here's a set of examples showing an individual who earns $40,000 per year at 3 different ages in each of the regions over time. This person is over the cutoff for connector care, and their affordability standard is a bit above 7% of income, which translates to $240 to $248 per month. In practice, they could have qualified for APTC to reduce expenses in any of the years shown, though the 25-year-old likely would have received a $0 APTC in most cases because of the state's competitively priced silver tier plan. This year, although unsubsidized premiums are not considered affordable in most scenarios, subsidies under the ARP would make these bronze plans available for a cost as low as $2.50 per month up to $136. So this slide looks at a couple earning $80,000 per year, which is over the 400% FPL cutoff, so out of subsidy range until this year. The affordability standard here is 8% of income, close to $540 per month. And the drop you see in the affordability standard from 8.05 to 8% over time is because in 2015, we mirrored the federal mandate standard, but after the federal mandate was zeroed out in 2019, we returned to the 8% cap that we'd used historically. In 2021, ARP makes subsidies newly available to this couple, and the resulting premium for this plan would be considered affordable in all scenarios.
Marissa, I'm getting a little confused by these. I'm sorry, maybe I haven't had enough caffeine. So when we look at the shading, that's before the ARP, and then when you're telling us they are affordable, that's I'm.
Yes, so this shading is the result of what you would do when you filled out your tax form, which does not account for subsidies. But okay. I wanted to caveat that in practice, a member looking for a plan might not see the price that's in the schedule if they qualify for tax credits, which is particularly true in 2021. Prior to 2021, there would have been no subsidies available for this person. So there's kind of nothing to factor in, and what you see is what you get in terms of a tax assessment for affordable or not affordable. Does that help?
Maybe. I'll ponder.
Okay.
Yeah.
Okay. And so lastly, here's a family where there's a couple with one child earning $100,000 per year. They also would be over 400% FPL and subject to the 8% affordability standard. But because of their higher income, that translates to a monthly premium of about $670. And you can see very similar trend over time and by age, as we saw in the other slides. But also here, ARP is putting post-subsidy premiums into the affordable range in practice if this family were to qualify, if they didn't have an offer of employer-sponsored coverage that would block them from tax credits or something like that. So let me pause here before I move on from these examples to see if there's any more questions.
So this is Matt. It would be interesting to view these shaded tables after the application of APTC. If I understand this correctly, what you're presenting is before the application of APTC. Is that correct?
That's correct.
And the state subsidy. I suspect, based on your earlier slide, then that we would see a good deal more green here rather than pink after the application of subsidy, which tells me that rising premium is borne among the subsidized population more by the premium assistance than it is on the individual member. And then, of course, for the unsubsidized population, because there is no application of that subsidy, they bear the full brunt of increases in premium broadly in the merged market. Am I understanding that correct?
Yes, and so these examples were done through the lens of the individual mandate, which does not factor those premium subsidies in. But that's why I did want to provide some of that additional context, because someone who's actually coming to look for a plan and shop, they would see a lower premium and some relief from those premium tax credits. Although that's not everybody qualifies for those. And so, I don't want to ignore this population of most concern who wouldn't qualify. But yes, you're right that premium subsidies do factor in here when someone comes to shop for coverage. And this is an assessment as part of the individual mandate that doesn't factor that in.
Thank you.
Mm-hmm. Any other questions before I move forward? Okay. So, zooming out now to look at how this plays out at tax time, I have here our most recent analysis of Schedule HC data, where individuals exempt from a penalty because they lacked access to affordable coverage are in the green sections of the bars. So I'll start with the full year uninsured population on the left, and you can see that the proportion of individuals in that unaffordable bucket grew over time from 22 to 28%. But underneath that, the absolute number of people stayed pretty constant, around 45,000 in each of those years. Coverage gains for the lowest income individuals meant that those with unaffordable coverage made up a larger percentage of the uninsured. And you can see that big drop in the bottom blue segments there, where we had about 33,000 fewer low-income uninsured as the ACA came into effect. The dynamics among the part-year uninsured look really different. The part-year uninsured tend to be higher income, and many of them are exempt from a penalty because they had only a short gap in coverage. The number of part-year uninsured without access to affordable coverage also dropped over this time period from 21,000 in 2013 to 14,000 in 2015. In terms of what to take away from this slide, I think that we made great progress in expanding insurance coverage through the ACA, particularly among populations that were eligible for low-cost coverage either before or after. And over time, really the only people who should be left in an individual mandate compliance chart like this are the people for whom coverage is unaffordable, as everybody who has access to affordable coverage gets enrolled. But I think that we have opportunities to make coverage affordable for more of this population that we can start to look to moving forward with this discussion. Any questions on this slide?
Marissa, but it also shows that half the people who are uninsured have an income at a level where most of them probably qualify for subsidized coverage, does it not?
It does. And so, there may be some other dynamics going on in there about, immigration status, but a lot of it, I think, is just people who could be gotten that we could work to outreach. And so outreach and education goes hand in hand with some of these other kinds of cost containment tools to really reduce the denominator over every year.
Why is it that the most recent data we have is 6 years old?
So we are working our way through 2016 and 2017 data. There was a change in the software system at DOR in 2016 that has required us to kind of rewire a lot of the behind the scenes data infrastructure we have to analyze this data. So I do have just a smidgen of data. So I have full year uninsured data from our preliminary analysis for 2016 and 17 that show that the population exempt due to unaffordable coverage grew a little bit to 50,000 in both of those years, but they represented an even larger proportion of the uninsured as those lower income people came into coverage. So the trend kind of continues. We're still working on the part year uninsured. And on the following slide, I do have some high level data that moves forward a few more years. But are there any other questions on this slide before I jump to that? I can't see everyone, so just speak up. So zooming out a little bit more, here's the overall insurance coverage that's reported on Schedule HC, which shows slow but consistent growth in the insured population even before the ARP, which led us to explore a bit more on another aspect of affordability, which is cost sharing. In the next section, we'll look at the experience of unsubsidized members, but I can pause here just before we move on from the individual mandate data to see if there are any last questions. So in terms of member experience, data collected from our enrollees in 2021 show about half of all Health Connector members felt their premium was reasonable, down from 68% in 2015. When we look at the subpopulations under that data, you can see in the top chart that unsubsidized members were significantly less likely to think that their premium and cost sharing amounts were reasonable at just 20 and 15% respectively. And the lower chart shows this data broken out by metallic tier, where only 9% of gold or platinum members thought that their premium was reasonable. Our survey also asked about whether cost was a barrier to care. Again, we've seen growth in members reporting delaying or forgoing care due to cost, about 1 in 4 unsubsidized members in 2021. One note I would make on this question is that we did see a number of respondents indicate foregoing dental or vision care, which, as you know, are not services covered by our health plans, though they are, of course, essential to good health. So we broke this concept out into 2 questions last year. So we could assess unmet needs for dental or vision versus unmet needs for medical care. And that's what you see here is the medical care question. Among those delaying medical care, they most frequently cited delaying diagnostic tests, routine or preventative care, prescriptions, and mental health care. So let me just stop here and see if there's any questions on the member experience data.
Marissa, with regard to the survey, especially the folks that were surveyed this past year, with regard to the delay of care, how many of those respondents did not receive care because care was not available? For example, with COVID, a lot of dental practices, based on recommendation from their associations, were not open for a while. The same thing holds true for many in healthcare, where there were limits that were placed by providers, healthcare providers, with regard to certain tests, certain procedures that they were going to do, or that they considered non-urgent during the COVID period. So how did we factor that into that question, those issues into the question?
Yep, we did ask that question separately, and I can pull those results and send them to you. I don't remember them off the top of my head, but we do focus questions like this about delaying or not getting care because of cost, because of trouble finding a provider that would take you. And we did embed in that kind of, if you couldn't find a provider, is it because they weren't doing anything or doing less of what they do because of COVID? And so I'll find those numbers and send them along. But this is purely cost in this question. Any other questions? So where does this leave us? We have high rates of coverage in Massachusetts, but there are still many state residents who remain uninsured due to a lack of affordable options. And even among those who are insured, out-of-pocket costs are a growing burden, preventing people from getting the care they need. Healthcare cost containment is a thorny and complex topic, but we will continue to look for ways that we can make coverage and care available to those we serve, including by working with DOI and other stakeholders to strengthen the individual market, enhancing our outreach work to help bring more people into coverage, looking at ways our product design can provide high value to members, and continuing to bring data like what we've shared today to bear on state and federal policymaking, including efforts to make ARP subsidy levels permanent. So I hope this is just the beginning of our conversation on this, and I welcome any feedback for future discussions.
Yeah, thank you for this. It's pretty stark.
She was raising her hand the old-fashioned way.
Oh, well, got to just jump in.
Come in, Nancy, go ahead.
No, go ahead, Rena. It's okay.
I just, you know, at the risk of beating this horse into the ground, I would like to go back to the conversation we had during the seal of approval. And I think that, and I'd like to also reflect on Matt's astute observation that as healthcare continues to become less affordable and as subsidies continue to increase, state and federal governments are paying the price for us not addressing the underlying drivers of healthcare costs. And as taxpayers, you know, I mean, take off our board hat. As taxpayers, that should be incredibly concerning to us. And I just I cannot emphasize enough, as a Commonwealth, we have got to stop making observations about the cost of healthcare and taking action to actually address
it. I certainly want to dovetail Rena's point. And if we look at the past year, there's very few action to justify some of the increases that we're seeing. For one thing, most folks have not necessarily been using healthcare because of the concern around COVID. We have seen limitations, or limits in service in terms of what's available, what folks can go out and get, or delay in services in certain instances. Yet we are seeing an increase in the cost of care that seems to parallel the availability of subsidies. So as more subsidies seems to be made available, that seems to be captured by the providers of the service. And really the folks in the middle who are not receiving these subsidies are being squeezed because that's where the pain is being felt. So while it may not be within the purview of this board, I think it's really important that we start to look at the real drivers of the increase in cost. Certainly, we're not seeing an increase in cost because there's an increase in the service. We see this example with the increase in Delta Dental. Well, a lot of dental offices were closed, but yet we're seeing an increase. So I think the real driver of cost is really something that this organization or other state agencies really need to look at so that we can have a real conversation around cost containment. Because right now we're not really discussing cost containment, and we're going to continue to see an increase in cost. And so I support Rena's point 100%.
Nancy?
I mean, I'd say we know endless amounts about the reasons why costs are going up, and we lack the will, the resolve, the political to do anything about it. It's very clear it's unit costs. It's very clear if we look at every other country. that we need to regulate prices, and we are collectively unwilling to do it for so many reasons. But
so, Marissa, that was a wonderful presentation. I think there's a lot of takeaways. Some of it, of course, is things seem to be getting a bit worse. Subsidies are crucial, a whole range of things like that, but I really do appreciate the data that you presented. So thank you. I think now we're going to move on to another agenda item that's going to be presented by Kayla and Michael on the Healthcare Sharing Ministries 2020 and 2021 responses to minimum credible coverage reporting requirements. So am I turning over to you, Michael?
Yes, thank you.
Okay.
So good morning, members of the board. Today, Kayla and I will be presenting the data the Health Connector has received from Healthcare Sharing Ministries who have complied with the minimum credible coverage regulations reporting requirement for health arrangements provided by an established religious organization for calendar years 2020 and 2021. I will be refamiliarizing you with the development and operation of the current MCC regulatory requirements that give rise to these healthcare sharing ministry reports. And then Kayla will walk you through the data from those reports and provide key takeaways for your consideration. Okay, starting with MCC. State law identifies specific types of coverage as meeting MCC, for example, Medicare and Medicaid, but otherwise contemplates that the Health Connector will issue regulations specifying when other types of coverage will satisfy a Massachusetts resident's health insurance mandate obligations. The regulations have accomplished this by doing two things. One, setting cost sharing, substantive benefits, and coverage administration standards for traditional commercial insurance products. And two, identifying programs or methods other than traditional health insurance that a Massachusetts resident could use to meet their individual mandate obligations, such as a high deductible health plan or TRICARE. So health arrangements provided by an established religious organization are one such non-traditional form of paying for healthcare services that the MCC regulations have recognized since they were first promulgated in 2007. Until the 2019 amendments, unlike other forms of coverage provided by private entities in this deemed MCC category, there were no additional criteria that such arrangements had to meet for an individual to use their participation in that arrangement to satisfy their individual mandate obligations. Those 2019 amendments were prompted by a particular type of health arrangement, healthcare sharing ministries, and two noteworthy occurrences related to them. One, rapid national uptick in healthcare sharing ministry participation. These are entities which are not regulated in the same fashion as health insurance carriers. And two, Massachusetts' own direct experience with Aliera, an organization marketing itself as a healthcare sharing ministry and its potentially illegal operations in the state. These developments raised concerns about the risks that those types of health arrangements may pose consumers. It's also worth flagging a recent concerning development involving healthcare sharing ministry known as Charity Ministries Incorporated. This entity, formerly known as Trinity Health Share, an arrangement known to be affiliated with Aliera, recently filed for Chapter 11 bankruptcy and ceased operations in July of this year. This occurrence further demonstrates the concerns about the performance of those types of arrangements that motivated the 2019 amendments have not abated. So looking at the actual substantive requirements, the 2019 amendments took effect as of January 1, 2020. And starting with tax year 2020, a Massachusetts resident can only use health arrangements that meet those requirements to satisfy their individual mandate obligations. So in brief, those requirements demand that the health arrangement is not a for-profit organization. They do not make any direct or indirect representation that the organization has sufficient financing to meet members' anticipated financial needs. They do not use compensated sales agents, sales tactics, or deceptive marketing practices, such as using common insurance terms. These entities cannot use funds paid by members for medical needs to cover administrative costs. They need to provide disclosures that the organization is not an insurance company and does not guarantee that medical bills will be paid. They have an obligation to report annually to the Health Connector about membership operations and finances, and they are subject to any other criteria the Health Connector may deem appropriate to ensure that individuals participating in those arrangements do so in arrangements consistent with these foregoing requirements. On that last requirement, it's important to note the Health Connector has not exercised its discretion there to impose any additional criteria. So it's really the first 5 bulleted items plus the annual report that constitutes the spectrum of requirements on health arrangements to date. The substantive requirements among those 6, those that speak to how arrangements must operate and interact with Massachusetts residents, are designed to ensure that individuals are only using bona fide arrangements. And the reporting requirement is what allows the public and the Health Connector to monitor how those arrangements, holding themselves out as MCC compliant, are in fact operating in Massachusetts. Now, the reporting requirement in depth, get the next slide, Kayla. Thank you. So an arrangement completing the annual reporting form has to respond to questions about membership, operations, and finances, as was stated. They have to provide additional supporting documentation, such as marketing materials or financial statements that back up their answers. And they have to attest to otherwise complying with the other substantive MCC requirements. Because healthcare sharing ministries were the only type of organization that filed reports during the time period in question, 2020 and 2021, the remainder of the presentation will be focused exclusively on them and the health arrangements that they offer, and not health arrangements generally. So before handing things over to Kayla to go through the data, I just want to pause if there's any questions about the regulations and how they operate.
Mike, this is Dimitri. Quick question.
Yes.
Just to be sure I understand. So there's no minimum coverage requirement with regard to the health ministries.
Could you clarify what you mean by a minimum coverage requirement? Do you mean substantive?
Actual value in terms of whether or not for everything that's on our shelves, bronze is a minimum actuarial value. For folks who may be looking at these things as an alternative to having coverage, or to get around the requirement for having active coverage in Massachusetts, what guarantee coverage are these organizations providing? Because from reading the materials that's been published with regard to these health ministries, it's not very positive in terms of what coverage they provide, or what they pay for, what they don't pay for, especially someone who has some real issues.
Yeah. So the MCC regulations as applied to health arrangements like healthcare sharing ministries only impose certain requirements as to their interactions with consumers and how they represent who they are and what they do. Unlike other methods of financing care that are considered by the regulations or state law, there really are no substantive requirements as to how much money needs to be spent on care versus administrative expenses. The MCC regs don't contemplate that, and otherwise these entities are not regulated in the same fashion as traditional insurance companies. So they are not otherwise subject to, financial testing in the same way, and they're not otherwise subject to the same forms of claims administration or operations rules or scope of benefits coverage rules. I see that Kevin has his hand up, and I don't know if that's to ask a question or to supplement the response.
To supplement what you've said, Mike, I mean, we at the DOI have had concerns about these entities. They are not insurance companies. They do not have insurance products. They're not subject to any insurance laws or regulations. I am not aware they've ever developed actuarial calculations of how they actually do operate. There have been a good deal of discussion with the connector and as part of the Merge Market Advisory Council that perhaps there needs to be consideration of new regulatory processes to regulate these healthcare ministries in general. I think absent any changes to state law, what the connector is doing is admirable to at least identify some criteria that would apply. Independent of that, we continue to have concerns about those who don't come to the connector and market products in the state, and individuals don't even get any protection. And it is something that we want to continue to monitor. And I know the Merge Market Advisory Council is at least looking at this and its report may actually have some recommendations about how to look at entities like healthcare sharing ministries going forward.
So if I understand correctly, you can avoid the ACA penalties, but not have a plan that meets the ACA actuarial requirements in one of these arrangements. Is that a basically state of the world?
That's my understanding.
Yeah, I think the tiny nuance there is the ACA penalty is now zeroed out, but there's a state penalty that you can avoid. But yep,
I understand. So,
And Mike, would you rather finish your presentation before we do more?
Oh, I'm at the transition point to
Okay.
hand off to Kayla. So if there's other questions related to the regulations themselves, I'm happy to take those now, or we can hand it over to Kayla to go through the data, and Kayla and I can take those questions at the end if that's.
So could the legislature, if it chose to, picking up on Kevin's comment, ban these or regulate them more heavily? Like, what's the range of possibility?
It's very difficult for us at this stage, given the novelty of the data, to really commit to what is or isn't possible or on the table. In the infinite.
Yeah, I'm adding like absent the data, and people
sure.
Could data and have different views about it. If one were of the view that these are not good entities from a consumer perspective, would a state legislator have the ability, if it chose to do so, to ban them? Is that permitted?
I think
they could ban them, or theoretically they could set up some kind of registration or licensing requirement so that there could be appropriate consumer protections. As a non-insurance entity, they could always put such registration requirements with any entity, whether it's the HPC, the Attorney General. It's more to make sure, if they are a choice that some do want to have, to make sure that they are an appropriate and legitimate choice so that they are following responsible standards.
So there's nothing under the ACA or other federal law that precludes an individual state from taking whatever action it wants to with these.
I'll speak for myself. I'm not aware of that.
Okay.
Right. We should probably move on. But thank you, Michael. I think we're up to Kayla.
All right. Thanks, Mike. I'm going to jump into the summary of Healthcare Sharing Ministry reporting form responses. So Healthcare Sharing Ministries attesting to MCC status provided membership, operational, and financial information to the Health Connector through the 2020 and 2021 health arrangement reporting forms. Forms submitted in 2020 reflect information from calendar year 2019, and forms submitted in 2021 reflect information from calendar year 2020. I'll start by providing some high-level information about the data collected before going a bit more in depth. So for membership, in 2020, 7 healthcare sharing ministries. Oops. Did someone have a question? No, okay. In 2020, 7 healthcare sharing ministries with at least 2,467 total Massachusetts members reported to the Health Connector. And in 2021, 6 healthcare sharing ministries with 2,170 total Massachusetts members reported to the Health Connector. 3 healthcare sharing ministries in 2020 and 2 healthcare sharing ministries in 2021 reported involvement with Massachusetts small businesses and their employees. And in terms of operations, in 2020 and 2021, most healthcare sharing ministries reported charging members extra fees or said they had issued penalties in certain circumstances, most of which were tied to what were referred to as violations of lifestyle agreements or pre-existing conditions. In both reporting years, most healthcare sharing ministries reported that they use third-party vendors, operate in all or most states, and use provider contracting. Okay, so again, I'll be providing more detail on financial data in just a few minutes, but at a high level, in both reporting years, members paid their healthcare sharing ministry more than the amount the healthcare sharing ministry paid out for members' healthcare bills, and about half of medical bills submitted by members were determined eligible for sharing. All healthcare sharing ministries charge members administrative fees, and all reported some type of negotiation of members' medical bills. Okay, so on to membership. So these are the 7 healthcare sharing ministries that submitted forms to the Health Connector in 2020, reporting again a total of 2,467 members. As you can see, Medishare, OneShare, and Christian Healthcare Ministries reported the greatest Massachusetts membership. In reporting year 2020, some healthcare sharing ministries, specifically Samaritan and Liberty, reported membership at the household level, resulting in underreported total 2019 membership. However, Health Connector staff updated the question about membership in the 2021 reporting form to clarify that healthcare sharing ministries should report membership by individual member level data, not the household level. These are the 6 healthcare sharing ministries that submitted forms to the Health Connector in 2021. Samaritan, CHM, and Liberty reported the greatest Massachusetts membership. Samaritan and Liberty's reported increase in Massachusetts membership from reporting year 2020 to 2021 is likely due to the more accurate membership data reported after the form was updated and not from actual enrollment growth in the state. It is notable that total membership reported in 2020 to 2021 declined. This could be due to the fact that Medishare, which reported having the most members in the state in 2020, did not submit a reporting form to the Health Connector in 2021. Christian Mutual MedAid also did not submit a form in 2021. However, they reported the fewest Massachusetts members the year prior in 2020. One new organization, Zion Health, reported to the Health Connector in 2021, but they only reported having 7 members. When discussing membership trends, it's also important to note that membership represented here only includes those healthcare sharing ministries that reported to the Health Connector for the purposes of MCC status. So there could be other healthcare sharing ministries within Mass, but we wouldn't know about them because they didn't submit a form to us. In total, 3 healthcare sharing ministries reported that small businesses in Massachusetts use their arrangements. Some healthcare sharing ministries like Medishare reported that while they don't offer health arrangements, employers in Massachusetts facilitate monthly share payments for their employees, while others like CHM reported that businesses in the state directly participate in their arrangements. Before I move on to operations, I can pause for any questions.
Kayla, do we have any way to know whether all of them actually filed? And did some that filed this year, should they have filed in 2020 or vice versa? Do we just get what we get and that's it?
So we know, just because we've had, just 2 years of reporting now. So we know that we had those 7 in 2020, and we knew that a couple dropped off. We gained one new one in 2021. But in terms of how many healthcare sharing ministries are out there in the state, and how many of those are reporting to us, we wouldn't know that. We just don't know about those entities.
And Kevin, is there any kind of national, I know the NAAC has been quite active on this issue. Is there like information sharing that would allow us to say, did some of the ones that are actually operating in the state not file?
I believe there might be some information at the NAIC level, and I have not seen many that are not on Kayla's list. So I think she does have the major ones that we have seen.
Okay, if no more questions, I can move on to operations. So all healthcare sharing ministries reported that they operated in all 50 states except for Christian Mutual MedAid, which reported being in 46 states, but did not specify which ones, and OneShare, which reported operating and advertising in all states except for Vermont, Maryland, Pennsylvania, and Washington. As noted, most healthcare sharing ministries reporting to the Health Connector reported charging members extra fees or issuing penalties in certain circumstances. Of the 6 healthcare sharing ministries with fees or penalties, 4 reported fees or penalties specifically tied to violations of lifestyle agreements or pre-existing conditions. And to give you a sense of the types of member fees or penalties reported, I'll just highlight a couple examples. In 2020, Medishare reported that second-time violations of their lifestyle agreement result in membership termination, and they state that such violation may include submitting medical bills related to tobacco use, injuries due to use of illegal drugs, or willful disregard for personal safety. In 2020 and 2021, Liberty reported that a member may no longer participate if they fail to fully disclose pre-existing condition information at the time of application. And similarly, Solidarity reported terminating members for not disclosing pre-existing conditions. Most healthcare sharing ministries reported using a variety of third-party vendors for a range of services. The following examples are just a limited sample of reported third-party vendors. You can see that some use vendors for services related to marketing, pharmacy benefits, data storage, and negotiating member bills. And most healthcare sharing ministries reported that they use some form of provider contracts. This ranged from single case agreements to contracting with provider networks directly. All right, I can move on to finances if no questions. Yep.
I just have one question. Do we know, and maybe I'm sorry if I missed this, if most people that are members of these organizations also have separate health insurance?
That's a good question. That is not something that although I don't know if the ministry would know that answer about their own members, but that's not something we know. I think I had assumed that they didn't, but we definitely don't have that data from this reporting form. And I don't know the answer to that.
It strikes me, obviously the sample size is not enough to really spread risk, and the finances you're about to show certainly can't be enough to pay for really serious medical bills if someone, I can't imagine. I should let you go through finances. So I'm a little uncertain, but anyway, I shouldn't hold you up since I'm going to eventually want to push everything along. So thank you.
Sounds good. All right, we'll move on to finances then. Okay, so health arrangements reporting to the Health Connector are required to answer a range of questions about the organization's finances over the past calendar year. On average, healthcare sharing ministries reported in 2020 that members paid their healthcare sharing ministry about 1.8 times the amount that the healthcare sharing ministry paid out for members' healthcare bills, and that about 50% of medical bills submitted by members were determined eligible for sharing. You can see in these bar charts how this broke down for each healthcare sharing ministry. So that first maroon bar is the amount paid in by members. The second orange bar represents the amount submitted by members for sharing to medical bills. The green bar is submitted amount that qualifies for sharing according to the ministry. And finally, the last blue bar is the amount the arrangement actually paid out for members' healthcare costs. Okay, so these bar charts show the same financial breakdown for 2021. On average, healthcare sharing ministries reported in 2021 that members paid their healthcare sharing ministry about 1.4 times the amount that the healthcare sharing ministry paid out for members' healthcare bills. And in line with 2020, about 50% of medical bills submitted by members were determined eligible for sharing. This table shows the cost paid for through the healthcare sharing ministry as a percentage of member contributions. In 2020, healthcare costs paid for through the healthcare sharing ministry as a percentage of member contributions ranged from 16% to 79%. And in 2021, the reported range was 28% to over 100%.
And just to clarify, these are across all the states in which the ministry operates, or is this just Massachusetts?
This is just based on Massachusetts data.
Just based on Massachusetts members.
We do have some of the national data, but not for every ministry.
And if we look at the national data, are the ratios fairly consistent?
I would say it's a little all over the place. Some are consistent across, just depending on how big their membership is. For some, they only have, they have very, very small membership in the state, so and much more in other states. So it just doesn't really compare well. So it really just depends on the ministry.
I mean, you would expect these to be quite volatile, just given the low membership.
Mm-hmm.
If they're spread across a bigger base, one might hope that they would be higher, and I guess in the case of the Christian healthcare ministry, a little lower. So,
all healthcare sharing ministries charged their members administrative fees. However, the fee structure and amount greatly varied. Some retained a certain percentage of member contributions for administrative costs. For example, Medishare reported an administrative fee of about 15.4% per member. Some healthcare sharing ministries like Liberty charged an annual and monthly fee. So Liberty reported that the initial 2 months of a member's contributions are used for admin costs. Then up to 12% of each monthly share is assigned to admin costs for the rest of the year. Members then also pay $75 in annual membership dues for admin costs. Some healthcare sharing ministries like Solidarity charge different administrative fees based on the program type and member demographics. So in 2021, Solidarity reported a one-time membership fee of $135 plus a monthly fee based on the program type, member age, and whether the members were purchasing a single, couple, or family plan. Okay, so in 2020 and 2021, most healthcare sharing ministries reported that medical bills are negotiated in some way, whether the healthcare sharing ministry negotiates on behalf of members, the members negotiate their own medical bills, or a third-party vendor assists with negotiating medical bills. All right, wrapping up here. In the first 2 years of the new health arrangement reporting requirement, the Health Connector received in-depth information about the healthcare sharing ministry's membership, operations, and finances. This information helped to clarify the extent to which these types of arrangements are active in the Commonwealth and shed light on the activities and operations of such arrangements. Health Connector staff made minor changes to the 2021 reporting form to improve clarity and quality of data, and we will continue to review the reporting form to assess whether clarifications or modifications to the form would yield better data. We will be sure to keep our equity lens in focus as we think about next steps on this topic and future policy approaches to the individual mandate and health coverage generally. So this is a very high-level overview, and the full report with all of the data is available on our website, and the link to where that report can be found is on this slide here. And I'm happy to take any questions.
Nancy
Yes.
has one.
Yeah.
Nancy,
So first, I actually raised my hand this time.
No, that's why I called on you, Nancy.
It's a miracle. A very good reinforcing better.
And then Dimitri.
So first of all, thank everyone for the work on the report. It's really terrific, and I think it does exactly what we had decided to do when we last discussed this, which was collect more data so we could better understand this. I guess my question is, now that we have the data, and at least to me, we know that these organizations are operating in a variety of ways that's contrary to public policy goals and rules, pre-existing conditions, the unfair claims practices, the MLR standards, these lifestyle agreements, the not giving people the range of benefits that we as a Commonwealth have decided people should have. What are we going to do about it?
I think we don't know the answer to that yet, Nancy, so I won't pretend to offer one, but I think the problems with these organizations are made manifest by this data.
Yeah, they are, which is the power of data. I think one thing which particularly troubles me is that there's no obligation on the entities to assess people who join them to see if they might actually be eligible for free or subsidized health insurance. And so I think as we think about the range of options, I would hope that that will be one that we'll think about, and it's clear from my questions. I think the legislature should ban them. But I think there are a variety of other ways short of that we could at least to create some additional consumer protections that might help people find their way to decent health insurance instead of joining one of these.
Thank you, Nancy.
Dimitri.
Well, Nancy stole my thunder, but absence regulation, are we able to perhaps survey the customers of those services so that we get a better sense here in Massachusetts, the satisfaction level in terms of whether or not folks who are entering these agreements that are making the assumptions that these folks are providing insurance coverage, because that's what they're doing, but they're not doing it under the insurance umbrella. Get a sense of what the satisfaction is for the consumer and whether or not folks are able to go to providers of their choice and those bills are being paid versus being sent to collection because they're making the assumption that they have an insurance carrier. Because the idea that these folks are not operating as insurance carriers in Massachusetts is a fallacy, because at the end of the day, people are going to these services to bypass the ACA requirement. So we should have a better handle in terms of what is this really costing us, and how many of those people are not getting services that they thought they should be getting, that are ending up in emergency room, which in the long run is driving up the cost of care and defeating the purpose in terms of what we're trying to accomplish here at the Health Connector.
So I'm a little worried about the prerogatives, privacy, and politics of reaching into these organizations' memberships to directly survey. But we will take a look at that. I think what's absolutely clear from the data is that as a proportion of the member claims filed, the vast majority of these claims are being denied as either unallowable or as unpayable. And I think to Nancy's point on public policy, that there's a kind of de facto public policy problem we can operate on. But we will take a look at that, at your question, Dimitri, to see if there's a mechanism to gain member input directly.
Dimitri, I think there's an enforcement record now against these entities. Both, I know the DOI has taken enforcement action in the past, which was mentioned in the report. So I think there are actually a lot of absolutely heartbreaking stories of consumers who join these not understanding what they were, often under pressure by organizations that they're members of, and then have an instance of incurring often very big medical bills and finding that they're not paid, or that the ministry does a gotcha in a way that we actually have not permitted in Massachusetts since 1985. So they're really rolling the clock back a number of decades and engaging in practices that we outlawed here back in the 80s in some cases. So this is not new public policy. This is well-established public policy.
So I'm going to want to push us along because I care a lot to hear about how the call center is doing, and Vicki is going to be up to talk about the call center. So I want to do a transition. Michael and Kayla, thank you very much for the information, and in particular for letting us know how to loop back with you if we have other follow-up questions. But for now, Vicki, we spent a lot of time thinking about the call center. Can you give us an update?
Yes, good morning. Today, I'm going to be briefing the board on the current status of the implementation. Audrey, can you move to the agenda page, please? So these are the items that I'll cover today, which is a refresher on the scope of the engagements, key activities and timelines, some work track updates, and then go live readiness. But I do want to reinforce that our guiding principle is to provide a reliable customer service experience to our members. As Liz said at the beginning of the meeting, our target date for go live is 10/12/21, and the focus is a smooth opening on that morning with a lead up to the October 23 payment deadline, and then the start of open enrollment on November 1st. Next slide, Audrey, please. So this is a refresher of the service that Accenture is bringing at go live on 10/12. We call this release 1. And these services really mirror what's in place today. However, on the next slide, you'll see that after go live, we'll be working with Accenture on a release 2 and what's intended to be offered in the future. Audrey?
So, yeah, just a slide. Next slide. Thank you.
So these are the once operations are stabilized, we'll begin planning with the Accenture team a release of additional capabilities, which will continue to improve the service that is offered and also broaden the channels available to members, which we know that members want, which is such as email and chat. Audrey, do you mind the next slide? So this slide provides a high-level view of the critical activities between now and the target date of 10/12. We've chosen the target date of 10/12 as the go-live date for the following reasons. It's a natural 3-day weekend, so that means that cutover does not need to take a day that we would normally be in operations. It also allows for more time in testing and validation of those test results. And then it also allows us to have more targeted training and practice sessions by frontline staff than if we'd gone live the very beginning of October. So we think that this is a very good date to choose. Next slide, please, Audrey. So I'm going to now go in high level of all the different work tracks that are part of this project. So hiring and onboarding remains on track. We work closely with Accenture to determine if any additional classes are needed prior to go live, but we're targeting 380 agents for go live. I would say that Wave 1 staff is in training and that 97% of our learners have scored 80% or better, and the average score is 94%. Wave 2 started on 9/7, and their first knowledge check, 100% of the learners scored 80% or better, and the average score for that class is 95%. And our third wave of learners will start on 9/13. The other thing that we worked with Accenture on is quality assurance. This is a framework we've put in place. There's 9 parameters. You have to achieve, once you're in your seats, 90% on all of those. But for the first 2 weeks of go live, the QA staff from Accenture will be monitoring calls real time by agent to ensure all staff meet quality standards. But these 2 tracks are in good shape. Audrey, do you mind the next slide, please? So data migration and phone transfers are 2 important parts of the project. Data migration is on track. We've planned 2 mock conversions of the data prior to the cutover weekend. The other thing that we worked on with business at Accenture and also CCA is we've determined the minimum necessary data to go live in case that there's certain data we cannot transfer at go live. So the rest of the data could be migrated after post go live. So contingency plans are already in place here. The other thing that needs to occur is our phone lines, which are currently with the telephony provider at Faneuil, need to be transferred to Accenture's telephony provider. So that work is targeted for 9/24. Accenture will take possession of those phone lines at that time, then point them back to Faneuil to use until the end of their calls, which are on 10/8, and then they will take over fully on 10/12. We did this in the last transfer, and it's typical for a call center transfer, but it's still important work that we need to monitor. Could you move please to the next slide, Audrey? So development and testing continue. They're ongoing. We're in our 5th cycle of development and testing. Most of our cycles are 2 weeks, but we added additional time to the 5th cycle to allow for completion of development and further testing. I would also say that Accenture has added more resources specifically to support testing of the cycles and also end-to-end testing, which is the cycle after this one. And we work daily and meet daily with senior leadership at Accenture to monitor progress in these 2 areas. The other thing that is required for us to go live is CMS approval for all the controls around privacy and security. The really good news is CMS gave us full approval for the project on August 6th. But then what needs to happen now is we still need to have Accenture do the work to put all the controls in place that were in their proposal to CMS. And they're working closely and vigorously with our state compliance officer to make sure that all of those are in place by September 17th. And this is a needed gate for go live. Could you move on, Audrey, please? So October 12th is fast approaching, and we're working closely with Accenture now on developing a cutover plan, which will start 3 weeks prior to go live, tracking day-over-day tasks for all the tasks and owners between CCA, Accenture, the incumbent, and any other third-party vendors. It gets down to hour-by-hour planning in the last, for cutover weekend, in the last couple days up to cutover weekend. We did this when we went live on all our other big implementations, so it's work that we're familiar with, as is Accenture. The other thing that is currently in plans and we're working on now is we're in the beginning of planning for a command center for the cutover weekend and the 2 weeks after go live for stabilization of operations. This will include additional staffing for any technology issues that customer service agents may have for logging in or accessing systems. It's the real-time QA monitoring that I spoke about. And then if needed, we will be taking groups of staff offline for additional targeted training. But there will be robust, full open lines for the cutover weekend and the 2 weeks after. Last, and as you can imagine, we continue to work closely with our Accenture colleagues on blocking and tackling whatever comes up that needs attention to be ready for our target for 10/12. Last but not least, we have go live criteria, which are listed here. We'll make a formal go no decision as we get closer to the target date, and we will apprise the board, of course, as to the final status of the cutover. And then I will be back in October to update the board. And at that meeting, the plan is we will have been live for 2 full days already, and I'll be reporting on operational metrics in production. Please let me know if you have any questions, but those are the ends of my presentation.
That is an enormous amount of work, both done and planned, and obviously stunningly mission critical. So I don't have any questions except thank you. Other questions for Vicki?
Vicki, do we need to contemplate any additional staffing in light of the MAGI, AGI thing? And if so, is that built into this?
So yes, we do. We've started those conversations as soon as this emerged last week with Accenture. That was not in the 380 that I talked to you about going live for November 1st, but those conversations are active and we'll do the best, planning with them. I'm hoping instead that we'll have something that means not everyone falls off the cliff at the end of December, but it is active, Nancy, and we'll then need to up our numbers.
Okay, good. And I just echo what Michael said. I know that in a few slides you've captured months of pain and hard work and effort. So we all thank you and everyone else.
Thank you. It's a big team effort, as you can imagine.
Vicki, thank you for all your hard work. Quick question around contingencies with regard to the cutover date, and subsequently, since we have a lot of new hires coming on board. Contingency in terms of addressing any potential shortcomings with the new hires as we had experience with the peers vendor.
Yes. So you'll see here, we've said we need 320 to be on the phones, Dimitri, as bare minimum. We're aiming for 380, and I think we have 400 and something. I want to say 407. I can find the number actually that's preparing to go through training. So every day we look at the numbers and attrition from training, and we have one more class that we can adjust, which is wave 3 or add a class. But again, 380 versus 320 is a good wide margin for buffer.
Thank you.
And then the other thing, Dimitri, just to follow up on your question, is one of the other things is this expanded help desk for the first couple days for logons. With the Monday holiday, we'll be able to test all the logons the day before we go live, but we want to make sure we have the support that if anyone struggles on the first day, we have instant ability to get them on the phones. I will say one last thing is Accenture, if you remember, supplemented during last year's open enrollment. So we do know that they're familiar we're familiar with their experience of managing remote and getting their folks logged on and accessible.
Well, I'm looking forward to the improvement that is to come with the change that's taking place.
Yes. Any other questions? All right, I'll see you in October. Thank you all.
Thank you, Vicki.
And Vicki, again, thank you and thank your team very much. And in the spirit of thank you, this is a really important and I think actually quite substantive set of discussions we've had, particularly around the challenges we face on affordability. If we can't solve the affordability problem broadly, this whole endeavor is going to face real problems. And that's much deeper than what we can do. And obviously the issues around the minimal credible coverage as really in many ways a consumer protection kind of issues that dovetails with what we do and really needs attention. But it's been, I think for me, a really enlightening discussion, but it sounds, as always, I am unbelievably impressed by the dedication and the work that the connector staff does. It's really remarkable between blending the policy challenges and the operational challenges. With all of that said, I'm going to ask for a motion to adjourn.
So moved.
Second.
Okay, Vicky, you can take the vote, and I want it noted that we're ending up on time. I'm not Vicky, I'm sorry. It's just, you're on my mind. Kathy.
Okay. Kevin,
Yes.
Michael,
Yes.
Ruth,
Yes.
Mark,
Yes.
Cassandra,
Yes.
Dimitri,
Yes.
Lauren,
Yes.
Nancy,
Yes.
Matt,
Yes.
Rena.
Yes,
Thank you, everyone.
thank you.
Thank you all.
Thank you.
Thank you all.
Uh,
Thank you, everyone.